Good morning. So we're done with cardiac and let's move on to respiratory. Let's talk about the respiratory function and alterations in gas exchange. So surfactant, well, let's talk about the development of the lungs first. So respiratory system development begins at around about day 26, and our fetal lungs have developed sufficiently to allow for respirations around 25 weeks. Surfactant is made by the cells in the airways and consists of phospholipids and proteins. It begins to be produced in the fetus at about 24 to 28 weeks of pregnancy and is found in amniotic fluid between 28 and 32 weeks. By about 35 weeks, most babies have developed adequate amounts of surfactant. And as a review, surfactant is that substance to keep your alveoli open. So again, as a review, you've got in the pulmonary system, you've got your upper airway structures that consist of the nasopharynx, oropharynx, and the laryngopharynx. And your lower airway structures consist of your trachea, bronchi, bronchioles, and alveoli. And just remember that there's two types of alveoli. Your alveolar type 1, I can't talk this morning, but it is 3:30 in the morning. So type 1 alveoli is the one that's responsible for respiratory gases, and type 2 are the ones that produce surfactant. Blood supply to the lungs comes from two sources, your bronchial artery system, and that supplies a small amount of oxygenated blood to the pleura and to the lung tissues. And then you have your pulmonary artery system, and that provides a capillary network for the exchange of oxygen and carbon dioxide. The capillary networks of the neonate, a young child, and elderly are less than those in the average healthy adult. And remember that oxygen depleted blood leaves the right ventricle by way of the pulmonary trunk. And so we're going to take a look at this here. The oxygen depleted or unoxygenated blood leaves the right ventricle by the pulmonary artery trunk, and then it branches into the right and left pulmonary arteries. The pulmonary arteries divide into smaller arteries, and then it goes into the arterioles until it goes into your capillary network, where again we said that that's where the gas exchange occurs in the alveolar capillary membrane. Pulmonary blood is unoxygenated, and pulmonary veins, the blood that is in the pulmonary vein is oxygenated, which is kind of opposite to the rest of the body, because arterial blood is oxygenated and the venous blood is unoxygenated. Okay, let's talk about the capillary network in your lungs. The capillary network is a low pressure system that can expand 2 to 3 times the normal size before any significant increase in pulmonary capillary pressures is detectable. And normally, while you're at rest, some of your pulmonary capillaries are closed and are not perfusing. And some of your pulmonary capillaries are open with minimal blood going through them. So, so when there is an increase of blood that's going to your lungs, your lung pressures are going to go up. So your lungs have to manage that somehow because you don't want to have too much pressure in your lungs. So what happens is that it has two ways that it does that, where it manages those pressures. The first one is recruitment. And remember that we said that some of your pulmonary capillaries are closed when you're at rest and it's not getting perfused. So the first thing that it does is it recruits those closed capillary vessels to open up so more blood can go through it. The second mechanism is distension. What that does is it allows for those capillary vessels to increase so they can allow more blood to circulate through. So the first thing when you have, let's say, a increase in blood flow to your lungs, so you don't want those pressures to go up. The way that your lungs will manage that is two ways. One is recruitment. It opens up those previously closed capillary vessels so more blood can go through them. And then there's distension, where it increases the capillary vessels, the caliber of the capillary vessels, and it also allows the blood to circulate through. So now your lungs can circulate more blood through it without its pressures going way too high. Another factor influencing pulmonary circulation is the fluid balance of the lung tissues. Fluid balance is regulated by hydrostatic pressure, colloid pressure, capillary permeability. And when fluid moves to the interstitium, fluid moves to the interstitium if pressures are high, and it if fluid shift is not controlled, it'll go to the alveoli. So you have, remember we were talking about that there's some fluids that are in the interstitium, and normally there's what do you say, like 7 to 10% or something like that. It just, and the rest of it gets sucked up by the lymph nodes. But if that fluid shift is not controlled, let's say something is wrong with the lymph nodes, it doesn't suck it up or it doesn't get reabsorbed back into the vascular system, then those fluid, they move into the alveoli. And what happens there is you get alveolar edema, which is actually worse than interstitial edema, because we said interstitial edema is that um, edema that's between the cells, right? But in alveolar edema, it's worse because it goes into your alveoli. What does it do? It causes an obstruction. It obstructs the alveoli from exchanging gases. Pulmonary interstitial and alveolar edema, it's common in CHF, pulmonary infections, and we'll talk about that. Also, acute respiratory distress syndrome. I don't need you to memorize this, but just know that there are some geriatric considerations. The lungs are a little bit stiffer because there's not as much elastin in there, and if they're a little bit stiffer, they don't recoil as well. So if you think about that, you're normally when you sit there and you breathe in and out, right? It Take a deep breath and let your breath out. So geriatric older patients, they don't have as much elasticity to be able to do that. They have enlargement of their alveoli also, which means that there's an increased dead space. Dead space is that area where it doesn't participate in gas exchange. And there's also decreased surface area. What does that mean? There's not enough area for gases to exchange also. So all these other things. Like I said, I don't want you to memorize this, but just be aware there's all these things that affect how we take care of elderly patients because of the difference that they have in a healthy, normal adult. Same with pediatric considerations. Their airways a little bit different in the structure, and then they have all these other things that are different from us. For instance, they have an overproduction of mucus in the area, in the trachea, so it increases them for airway obstruction. They have narrower diameters in their bronchi and bronchioles, so they're got high resistance to volume of air when they breathe it in. So those are just examples of geriatric and pediatric considerations. So I want you to kind of read through that and picture it. Picture how that would, for instance, how does that create high resistance? What does that mean when we say that? So ventilation is the process of moving air into the lungs and distributing air within the lungs. We have measures of ventilation, and there's lung volumes and lung capacities, and those numbers vary according to each person. And also it depends on your age, and your body position actually can change your lung volumes and your capacities, and we'll talk about that also. Testing of pulmonary function, you measure these volumes and capacities. This is an incentive spirometer that you're looking, and if you have not learned how to use this yet, you will. And we're going to take a look at these differences. So here's all this. What is the IRV, VT, ERV? And we'll take a look at all of those because there's a huge difference. And it'll make a lot more sense here in a minute. So what's the inspiratory reserve volume? It's about 2.5 liters. This is your air that's inspired with maximal inspiratory effort in excess of the tidal volume. So I guess before we talk about IRV, let's talk about the tidal volume. Tidal volume is about 0.5 liter, and we calculate if I have to intubate a patient and I have to put them on a ventilator, I have to calculate how much their tidal volume is. And what is tidal volume? Tidal volume is that amount of air that moves in and out of your lungs during inspiration and expiration. That's just your normal breathing. So as you're breathing in and out, watching TV, for instance, that's your normal tidal volume without any effort, just your normal amount of air that you breathe in and out. Then your IRV is that air inspired. So you take a deep breath and then you take a deep breath some more until you can't anymore. That is your IRV. So tidal volume is one way you breathe the air in and out normally without any effort. And their IRV is that extra amount of air that you breathe in after you breathe in your normal tidal volume. So your tidal volume is about 0.5 liter and your IRV is 2.5 liters. So the breath, if you think about it, the breath that you're taking now is a lot less than what you could inhale if you really inhale all the way till you can't anymore. So let's talk about your expiratory reserve volume, your ERV. This is about 1.5 liters. So you have your tidal volume where you are breathing in and out normally without any effort. When you take your normal breath and then you exhale all the way until you can't exhale anymore, that amount of air, that volume of air, that's about 1.5 liters is your expiratory reserve volume. So it's the amount that after you take your normal breath and you exhale all the way and you can't anymore, that is your ERV. So even when you exhale all the way until you can't anymore, there's still some air that's left in your lungs, and that is called the residual volume, and that's about 1.5 liters also. Let's start putting these capacities together, these lung capacities together. So your inspiratory capacity is your IRV plus your VTAC. So remember, it's inspiratory. So it's the amount of normal air that you would breathe in without any effort. And then you add in that extra if you take a really deep breath until you can't anymore. That's your IRV. So your inspiratory capacity, it's the amount of air that you can inspire or breathe in until you can't anymore. Your functional residual capacity is your ERV. It's the amount of air that you exhale all the way, plus your residual volume. So it's that amount of air that from after you take your normal breaths, which is your tidal volume. So you breathe all the way out till you can't anymore, your ERV, and then the amount that's left in your lungs after that, your RV. So you put that together, and that is your FRC. Your vital capacity is the maximum volume of air that's exhaled after maximum inhalation. So that's your IRV plus your tidal volume plus your ERV. So it's all of the air that is in your lungs. So when you take a really deep breath, until you can't anymore, and and then you breathe out all the way until you can't breathe out anymore, that is your vital capacity. The only thing that's not added on there is your residual volume. So inhale all the way and then exhale all the way, that amount of air is your vital capacity. Your total lung capacity is everything. So it's about 6 liters. It's when you take all the way breath all the way in and exhale all the way out, and that also includes your residual volume, the air that's left in your lungs after you take a really deep breath until you can't anymore, until you exhale until you can't exhale anymore. So your total lung capacity is a combination of all of those. I think I mentioned dead space earlier. So an anatomic dead space, so dead space is any part of the lung that doesn't participate in gas exchange. And anatomic dead space is the volume of gas that's in the conducting airways from the nose to the respiratory bronchioles. And then this, just know that there are some differences in adults to the elderly. How about alveolar dead space? Um, so this is alveolar, so this is at the alveolus level. This is composed of ventilated, so you're ventilating that part of the lung, but it's not getting perfused for some reason. So this is why they call it wasted ventilation, because you're ventilating it, meaning you're putting air in there with some oxygen and things, but there's no gas exchange. So there's no perfusion going on. So that's called the alveolar dead space. The physiologic dead space is just it's called the functional dead space. It's sort of the sum of the anatomic and the alveolar dead space, and that's about 1/3 of each breath. And your minute ventilation is the amount of air that you breathe in or you breathe out over a minute, and that is the tidal volume, your tidal volume, and your respiratory rate. So obviously, if either element goes up, like if your tidal volume goes up for some reason, or most likely your respiratory rate goes up or down, then it affects the amount of air that you breathe or breathe out over a minute. So that's just the formula for it. So your tidal volume minus your anatomic dead space, volume multiplied by your respiratory rate, that is your alveolar ventilation. So your alveolar ventilation is affected by both the anatomic dead space and the respiratory rate. And most likely, so when you're breathing, when you take a really deep breath, you're actually getting more alveolar ventilation than when you're shallow breathing. So let's say you're panting, you're breathing really fast, you're not getting as much air into the lungs, and so your alveolar ventilation is not that great. So when we take a look at the mechanics of breathing, so we know that when you inhale, your inspiration, your chest wall goes out, the muscles in your chest pull your lungs out, and your diaphragm goes down and your lungs expand. And that passive expiration, your lungs recoil and your chest wall moves in again and your diaphragm moves up. So that's your breathing.